Mr. Chairman, ladies and gentlemen, first of all, let me thank the organizing committee for this kind of invitation, of course, Professor Sarkis, Abu Jadeh, and also Sameh Mansour, that he made a lot of good introduction with his first presentation. And of course, my old friend Antonio Frange from Zurich, when we were working together in Zurich. Now he left and he went to Munich, and of course he will have a better life. But of course, after what has been said by Sameh Mansour, I think that my 10 minutes will be enough to say about retrograde approach. I would say that, how can I go back? Let me see. Okay. Okay. So this is, I want to show this slide because this a few slides is because I think these are important to explain why I started to do CTO revascularization. This is a case you can see from the old film. It was 1987. This patient had nostemi. I'm not so old, but I will show you why I show this case. So this was a 51 years male. He presented with nostemi, and as you can see, there is no pointer here, but there is a circumflex occlusion here, and then the patient, and of course this was a dominant circ, and then the patient also had at that time, of course, a right coronary artery. He was also with pacemaker because of some problem of during the nostemi case, and the case after that. The patient, this was his LV function, seems to be good, so basically no treatment was done apart of medical therapy, and the patient was okay until for 17 years, when he came back for a stable angina in 2005, and as you can see, at that time there was still some occlusion, well, there was still the occlusion of the circ, and it is interesting that now it's getting much bigger visualization because of these collaterals from right. And it was interesting that I cannot show you for simplicity, but the operator seems to be very interested in this left system and implanted 3 stents, one on this obtuse margin, one on this proximal LAD, and one also on this distal part of LAD. Because he thought that the circumflex was not really important. At that time, the patient then performed myocardial scintigraphy, and there was clearly a big, large amount of ischemia in all infralateral segments, and then I proceeded with, despite the other intervention was not so happy, I proceeded with recanalization of this circumflex. I tell you that this was one of my first retrograde approach. It was a little bit cumbersome, but anyway, to make the story easy, we went through this epicardial collateral from small right, and then we did a CAR technique, and then after removal of the wire from retrograde, we recanalized, as you can see here, the removal of the wire from retrograde, we recanalized the circumflex, and the circumflex was quite large. But what is interesting that the patient was okay for 1 year, and then the patient came back 1 year later. And as you can see here, all stents on the left systems are basically critically occluded except the circ. And this was the angiogram. And this angiogram showed to me that probably what I did with circ was very interesting for the patient, because at least I was able to make him, let him going back to the cath lab, still alive. And in fact, at that time, then he was retreated on the left system. So this is something which was impressive to me, and basically brought me to approach CTO revascularization. At that time, in 2007, we had the first cases from Japanese Kato and Tsuchikane, who were showing that basically through the collaterals we were able to go into the CTO from retrograde. And this was really very attractive and very important for us. But why retrograde approach? I mean, most of the time, retrograde approach is used when the entry of CTO is difficult to identify. There is also a side branch, and also when there is a good approach from retrograde. This is the most important issue because, of course, if you have a tapered distal end, retrograde approach will be much easier, and also to get into the true antegrade occlusion will be much easier too. And that, doing like that, we in 2008 we started our experience in Europe. As you can see, these were the first centers that were using CTO revascularization, retrograde CTO revascularization. There was Catania, there was Rotterdam, there was other centers in London, in Germany. But as you can see, differences among centers were mainly due to the fact that some were using retrograde as a primary strategy. Myself in Catania and in Rotterdam, there was George Sianos, and other people were using retrograde immediately after failed antegrade or retrograde after previous failed antegrade. So differences among centers at the beginning, and indeed in this editorial by David Canzari, he was saying that he's uncertain whether the retrograde approach should be considered as a default for instances of failed antegrade or as a primary strategy in selected cases. And indeed, this was 2009. Now, after more or less 10 years, we are totally changing our attitude. Why? Because, of course, there are differences mainly in microcatheters, wires, and also techniques and devices. So this is basically, as we discussed before, Mansour, as was saying, Dr. Mansour, we have to plan properly the retrograde approach, because of course we need to understand whether this retrograde may help you to have more success than antegrade approach. And I would say that the most important indication for retrograde approach when you want to do as a primary procedure is, of course, when you can see that antegrade wiring seems very difficult in terms of anatomical factors. And in this regards, of course, complex CTOs, we consider the longer, more than 20 millimeter of lesions, calcified lesion, and of course tortuosity. These are the most relevant issues when we are talking about complex CTO. Of course, we need to have a patient with visible and continuous collaterals, although sometimes we cannot even not see collaterals, and still with the technique of surfing we might be able to succeed. Of course, the donor vessel is healthy, this is a must, and probably reattempt after previous failure is an indication as a primary strategy. Of course, after that, we make the planning. The collateral analysis is the most important issue. And as you can see, this is depicted in this cartoon, but of course when we look at the collaterals, it is probably the ideal collateral will have a more than 90-degree donor exit. Of course there will be clear connection, there will be side branch size which will be really big, there will be no tortuosity in the collaterals, and there will be no bifurcation, and also the recipient vessel will be more than 90-degree insertion of the collateral. But this is of course the ideal collateral. The real life collaterals are totally different. As you can see here, this classification made by Gerald Werner is telling us that we can have CC0 and no continuous connection like this and still have successful CTO retrograde PCI. We can have CC1 thread-like connection, small, you see as the blue arrow, very small thread line, and then we can get it very easily. And then also we can have sometime continuous small side branch-like size collaterals, and still if there are tortuosity, you cannot even get into the collateral. So this comes a little bit difficult to predict sometime the collaterals. Generally speaking, we can say that the epicardial and atrial are a little bit more in terms of course potentially easier, but at the same time the corkscrew-like morphology, which is more frequent in epicardial, may be more complex to proceed with wires. And also we have to remember that of course these are not undilatable lesion, undilatable collaterals, while for the septals usually there are less corkscrew morphology, so probably a little bit easier for these things and for these reasons, and also they are dilatable, and so of course this makes the procedure easier because of the passage of the microcatheters and so on. But of course, after collateral cannulation, which is of course requiring a microcatheter, also a microcatheter are relevant for our procedures. And as Mansour was saying, of course, probably Corsair and also the more recent Caravelle are the capability to be used in the more complex retrograde approach. And this is true, as we see in our registry of the CTO club, that basically Corsair is used in more more of the 40% of the lesion. And of course, this extraordinary trackability is able to go through something that probably in the past seems to be almost impossible to go through. As you can see, this is a typical epicardial collateral, very tortuous, and still you can see this microcatheter is able to navigate into this epicardial collateral, similar to this other very cumbersome epicardial collateral where the device is able to go. So this is something that in the past was almost impossible to think, and now is probably the reality most of the time. Also, Corsair has been developed in a new fashion called Corsair Pro that has the capability to be used for in a very steep angle, and as you can see, this movie, if it works, I don't know if it does work, okay. Anyway, this is able to show you how this flexibility of the tip get into even a very steep bend of the
だって確実にだってロープの先端が穴の
This is a
方向向いて
phantom,
ないで
but
す
is of course something that is usually the case. You can see here how the flexibility of the tip is making a very steep angle, making successful Corsair. And of course, after the microcatheter, of course, the most important issue is wiring. And of course, regarding wiring, also a lot has been said. We must say that, of course, the new revolution comes from the new wires which have no whip motion. So in other terms, every time you turn from the proximal hand, you will have a one-to-one movement of the wire, and this is of course the new composite core of this Fielder XTR and also of other wires, where basically, as you can see, as compared to the previous wire, you have a one-to-one movement of the wire inside the artery, and this is making everything much easier, especially when you want to selectively get into the collateral. This is a typical example where you probably see a very big epicardial collateral, tortuous collateral, but a lot of very few faint septals. And still, after tip injection of the microcatheter, you are able to see that seems to be a small CC1, probably like thread artery, and then at the end, with this wire, with this, of course, designed for septals, you can get it very easily inside the septals. But of course, also, we have to remember the more recent Ascision family, which is again no whip motion, so same technology, especially for epicardial collaterals, and also for branches that are, of course, more tortuous. This is an example of a very tortuous epicardial branch, epicardial branch collateral. And as you can see, that it seems to be that many years ago it seems impossible to go through this collateral, and once again, with these new wires, Sion wires, you can see that it navigates into the artery, goes into the diagonal, and then of course the procedure is completed by the usual trapping into the antegrade wiring, and then reconstruction by drug-eluting stents. And but of course, more recently, in the last year or so, also another new wire came on the market. This is called SUO3. Is the specific dedicated for retrograde collaterals, and especially for epicardial collaterals. Does it have a more less tip load, so more flexible than the previous Sion blue wires? As you can see, 0.3 as compared to 0.8, but what is interesting that it has the same support of the Sion, so the same high support, and this makes this wire exceptionally good for those branches that are really very almost invisible. As you can see here, and also by the tip injection, it seems to be that there are branches, a lot of branches of septal collaterals, but not really clear hand. And then actually the most difficult part of the collateral comes from this wire, which gets through very easily exactly in the place where you really not think that this wire would get through. So this means that is of course something that this is then at the end of the reconstruction of this of the wire. So this means that of course wire are getting a lot more in this field of action. Then, of course, we need to know that a microcatheter should cross, should reach the distal CTO, and then comes the strategy. The strategy nowadays more employed is the directed reverse cart, where basically the balloon is inflated in the antegrade fashion, and then the microcatheter is aimed with a new one-to-one wire like Gaia directed to the dilatation, and then getting into the opening of the proximal cap. But of course, this is sometimes not so easy, because of course this directed called directed reverse cart technique end up sometimes in a sort of old-fashioned reverse cart technique with a lot of dissection around the proximal cap, and sometimes difficulty of the two branches to regain in the same subintimal space. And this is the reason why many times we have to knuckle, and we have to try to find a way with stiffer wire, polymeric wires, or sometimes we have to regain into the sort of gadliner, which is a way, an elegant way to re-enter instead of making the trapping inside the guiding, in the proximal guiding. To make the story short because of the time, we have to remember that experience in this retrograde dedication is very important. In this paper, which is quite old, by Thompson, he was showing that experienced retrograde operator is a must, especially for retrograde procedure. As you can see, the percentage of success is increasing significantly. And we showed similarly same concept in our study. In the retrograde registry, we understood that when you have an operator who has more than 100 retrograde PCI per year, success is more or less stable despite the complexity, the higher complexity of the CTO lesion. While for those operators who have less experience, retrograde procedural success is decreasing with more complexity of the lesion. And in this meta-analysis of the more recent study on retrograde approach, as you can see here, we are going from 2007, 2008, our first retrograde study in Europe, to 2013. We have now the result that basically procedural success is more or less around 83%, but specific the retrograde success is no more than 75%. And of course, what is of course the question before, the complication, major complication are basically below 0.507%, and other complications are not so threat-like, of course causing death. And in these situations also, when we discuss minor complication, we have to think and remember that collateral perforation, as you can see here, is about 7%, and also target vessel dissection may occur, but all other major complications are basically still again below 2%. In our experience in this retrograde CTO recanalization study, we discuss not only the percentage of success, we showed not only the percentage of success, which is around in the years going from 71 to 80%, but also what is important to understand that if you have a success, of course your clinical outcome will be much better than a failure, and this is of course not only for the antegrade but also for the retrograde. And also the predictors also for retrograde approach are basically, a part of failure, the JCTO score more than 3, so more complexity, left ventricular ejection below than 35%, prior PCI, and the male gender. And of course, these are all in this major table, which summarize all retrograde work experience with more than 130 patients. And as you can see here, our study, which is the one in Europe, is the biggest one published up to 2015 with 1,600 cases, with a percentage of success of 76%, and also interestingly the major percentage of collateral, which are of course still up to 2015 septal collaterals with different technique, wire crossing, knuckle, reverse cart, technical success 75%. So going back to to our, of course, other studies. Of course, different studies can be compared, especially for the fact that, of course, before and after Corsair introduction or channel dilator introduction, there is a big differences, and also before and after new wires have been used, of course, there is a big difference. But of course, this is mainly due to the technology and, of course, not to the expertise. And in conclusion, so I would say that number of retrograde PCI, CTO PCI is increasing significantly during the last 5 years, especially during the last 5 years. And we can say that overall success is around 75%, but this is because we are treating spatially situations that are not able to be assessed and recanalized by an antegrade approach. So this means that, of course, this 10%, less than 85%, is due to this problem. Retrograde may be used as first-line strategy and is more and more widespread use, especially when you have a very good collateral circulation, favorable collateral circulation, and other criteria. And this is, of course, in our EuroCTO club experience, this is the 30% of the time. Septal collaterals still the preferred use, 60%. However, epicardial collaterals are used are increasing up to 30%, especially in the last few years because of the new wires like SUO and Sion wires. We have to say that as compared to the past, as the presentation, one of my first retrograde approaches I showed you in 2005, less and less contrast and radiation exposure are used, and this is something very important. Usually, when you need to be a retrograde operator, you need to be an operator which has you should have much more experience, because more you get experience retrograde operation, more than 100 case per year, and of course more success you will have with the increased GCTO complexity. This is of course sometimes not possible to get in the same lab, but this is something that of course we should try to reach. Successful retrograde CTO PCI is associated with favorable long-term clinical outcome and symptoms, and this is something that of course we also showed in our registry, EuroCTO registry, and I will show you later in my next presentation. But what is important for us is that severe complications are below 3%. And this is probably a little bit higher than complication in standard PCI, but we have to remember that these are not standard PCI, but are a little bit more than complex PCI. And if we compare CTO to complex PCI, but the percentage of complication is exactly the same. Thank you very much for your kind attention.